Okay, it's 12:01. Let's go ahead and get started. Hi, everybody. My name is Joanna Smith. I'm a behavioral health consultant for the Southeast Michigan region for Michigan Opioid Collaborative. Thanks so much for joining us this afternoon. This is our webinar on enhancing access to medications for opioid use disorder, presented by our staff physician, Dr. Eliza Hutchinson. We are going to get started in just a moment here, but before we do, a couple things to go over real quick. You'll notice this is on the screen here, we have the CME information. If you're trying to obtain CME credits for today, you can feel free to follow the instructions here or use the QR code. We'll also be posting information in the chat on obtaining social work credits as well as McBAP credits. So keep your eyes posted on the chat for those to be posted shortly. Let's move on to the next slide here. So please, if you could make sure you're muted if you're not presenting or during the presentation. If you have any questions, please feel free to post them in the chat and we'll get to those either in transition of slides or at the end during our Q&A session. Like I mentioned before, if you haven't already done so, please sign into the chat with your name, your email address, and the organization that you're with for attendance purposes. And so we can follow up with you with slides for today as well as other information. As I mentioned earlier, PDF instructions will be posted in the chat for McBAP credits as well as social work credits and CMEs. If you could please complete the process for getting those credits within 48 hours, the links to obtaining those credits will expire within 48 hours. So please make sure that you complete that by Friday, March 31st at 12 p.m. You'll also, as I mentioned, be receiving a follow-up email including the slides from today and the credit information for obtaining credits that are offered. So before we officially get started, just want to give an overview of the services that the Michigan Opioid Collaborative provides. So generally, the Michigan Opioid Collaborative is a grant-funded program aimed at increasing the availability of medications for opioid use disorder treatment in Michigan, as well as bringing awareness and education around all other substance use disorders. MOC offers free same-day consultation services to providers for any patients with a substance use disorder. We offer quarterly introduction to buprenorphine trainings, as well as webinars on a variety of topics around addiction, healthcare, and substance use. We provide support for diagnosis, treatment planning, and medication management for patients with substance use disorders, including pregnant and perinatal patients. We have a hepatologist on our team who offers Hep C treatment consultation within 48 hours. She also facilitates a biweekly case consultation webinar to review cases with providers, and she's developed a 3-part webinar series on hepatitis C treatment. We've also created toolkits for providers to have additional resources when treating patients with different substance use disorders. If you have any questions, please feel free to reach out to your local behavioral health consultant who will be following up with you after today's session. You can also visit our website, which I'll post into the chat shortly. So I am about to hand it over to Dr. Hutchinson. Before we get started, just going to give her a brief introduction. So Dr. Hutchinson is a family physician in Ann Arbor and a consulting physician with the Michigan Opioid Collaborative. She currently provides primary care at Briarwood Family Medicine and addiction medicine services at Packard Health. She has extensive experience providing care for people living unhoused, those with substance use disorders, and justice-involved individuals. She's an enthusiastic advocate for harm reduction principles, innovative models of care for marginalized populations, and decreasing stigma for individuals with substance use disorders. So with that, I'm going to hand it over to Dr. Hutchinson.
All right, thanks so much, Joanna. And if it's okay, I'm going to share my screen because I have a very slightly updated set of slides. So let me just do that. Bear with me here. All right, can you all see that okay? That
Yep,
good, Joanna,
good.
can you get me on? Awesome, fantastic. Well, pleasure to meet you all and be with you today. Thanks so much for joining me. Couple of things before we get started. So I really want this to be as discussion-based as possible. One of the things that I most love about giving presentations is I learn a ton from the audience. Everyone asks great questions. I get new ideas for my own practice. And it also helps us at MOC kind of figure out what are other things that we can be offering to our communities. So please feel free to interrupt, either unmute yourself. You can either put something in the chat. I can't see the chat, but Joanna, if you'll give me a shout if anyone puts anything up there that we should address as we go along. And then I think hopefully we'll have some time at the end for additional discussion. So please, chime in anytime you absolutely need to. So I don't have any disclosures other than probably I feel really passionately about this topic, of course, and that comes from somewhat from data and just from my own experience. My prior work was working out in Seattle at a low barrier clinic located in a syringe service program. So a lot of my perspective sort of comes from that. So that's, I guess, sort of my own biased viewpoint. And the other heads up I'll just give is I tried to make these sort of generally applicable, but it is probably a little bit prescriber and provider heavy. So I apologize for those of you who are not providers, but I hope you'll be able to bring some of these tips back and persuade your providers, since we all listen to our social workers and all of our other collaborators. So apologies if it's a bit tailored toward providers. So with that being said, let me see if I can get to my next. So these are going to be our objectives. So again, we're going to be trying to just sort of initially identify barriers to accessing MOUD or medications for opioid use disorder in many existing care models. And probably goes without saying, but I will say this is going to be mostly focused on buprenorphine or bup, I might call it, or Suboxone, a little less on methadone, although I think some of these can also be applied to methadone and Vivitrol, but primarily focused on Suboxone. And going to aim to kind of explain how specifically low barrier practices, as they're defined in the literature, can help us address obstacles to care. And then I'm hoping we can really dive into identifying achievable action steps that we all can take, whether they're small scale or large scale, that will help improve patient engagement in whatever your care setting happens to be. So this is kind of what we're going to try to chat about. Why do we need to change anything at all? What's not working? And then what is low barrier care, sort of as it's defined in the literature, and is it actually any effective? And then we're going to try to look at some action steps and finish off with how does this look in some different care models across the country in real life. So, what isn't working currently? I think we all can recognize there are things that aren't working, even though we're all people who are working tirelessly to help folks with OUD. But as we all know, we're still seeing a phenomenal number of deaths every single year, despite all of our collective efforts. We also are seeing that people with opioid use disorder really want to reduce their opioid use. This came from a syringe service survey done back in Washington, and almost 80% of folks are saying that they absolutely want to reduce or stop their use. Additionally, people are telling us what kind of help they want. So the diagram on the right is showing the types of care and help that people are wanting. And of course, it's all over the spectrum. People want a lot of different things, but top that people want is medications for opioid use disorder. So methadone, Vivitrol, or buprenorphine. And you can see the breakdown down below there, but primarily buprenorphine is what people are asking for. And rightly so, because buprenorphine is a phenomenally powerful drug. What we know is that it has about 50% decreased mortality rate. So even if a person takes it for one single day, that decreases their risk of an overdose death by half for that given day, even if they do not take it long term. So powerful medication, people want it. Despite all of that, we know that most people are not actually receiving OUD-specific treatment. This is, of course, for a complex number of reasons, but kind of what I'd like to discuss today is certainly the care models that we've designed is a big piece of why we have this low rate of treatment for folks. So if we're going to think about care models of treatment, I like to kind of step back and think about, what are we trying to treat and sort of what do these chronic conditions look like? These are my own little arrow drawings, and this is kind of how I envision buckets of types of patients really with any chronic disease, diabetes, COPD, or opioid use disorder. So I kind of think of, the folks on the left who tend to have probably some more stabilizing factors in their lives, and they sort of get started on whatever treatment. So say it's diabetes, they get started on their insulin, they come for their follow-up appointments, and their A1C improves, and we overall see their disease improve in a pretty linear fashion. Similarly for OUD, we certainly all know patients who have engaged in treatment. They've started on buprenorphine or some other MOUD. Their drug use drops away pretty quickly. They make it for their appointments. They get their job again, reconnect with their families, and they're sort of off to the races and doing well. However, on the right, and this is arguably where I think a lot of folks with SUD are, but also folks with diabetes and other chronic illnesses, are that, overall the trajectory is still moving toward healing and recovery, but it's often a much more meandering pathway. Right? So folks, again, if we want to use our diabetes analogy, they start on their insulin, but then they can't afford their insulin. So they go off and they don't show up for care for a couple of months. So they kind of go off to the side and they return to care and their A1C is sky high. Somebody tries to restart them. Then a holiday comes and they sort of binge on delicious holiday food, and that makes their blood sugars worse. But eventually they're sort of working their way toward better glucose control. Similarly, we see folks with OUD, obviously, who are in and out of care for lots of different reasons. People go on and off their medications. People struggle with returns to use. And so we need systems of care that will meet them in that place. Arguably, our traditional care for people with OUD and SUD has not really paralleled that for other chronic diseases. In most chronic diseases, in a typical primary care clinic, if someone is struggling with their diabetes, the care will be intensified for them, right? They'll get meetings with nurses, they'll get outreach, they'll get a lot of extra TLC. And sort of we haven't typically and traditionally modeled that same sort of care for OUD. And so why is that? Why have we designed care models that are so disparate between these conditions? Part of it to me is really understanding the history of how we've understood addiction. So I sort of think about, just brief historical tour, back in earlier than 1970s, 1980s, we really saw that addiction was understood to be sort of a criminal disease, a moral failing. It was not a chronic medical condition. And the logical solution, of course, with that understanding is more sort of punitive. So that meant incarceration. That also meant care models that leaned a bit toward more a punitive stance than sort of a supportive treatment stance. Then as we went along, we saw sort of a shift in understanding addiction and substance use disorders to be more of a chronic disease. This is evidenced by 2016 and 2018, the Surgeon General reports really called for addiction to be treated as a chronic relapsing brain disease, same way we would treat other chronic conditions such as diabetes. And then we've sort of seen further moves recently, in Biden's recent report that was put out, there's a lot of support, not only for addiction as a chronic disease, but also for increase in access to MOUD and specifically harm reduction services as well. So we're really, seeing a shift in how we understand substance use disorders. And I think our care models are starting to follow, but need to follow that even more as we gain that better understanding. So that sort of is where low barrier care to me enters the picture. Before we actually dive into low barrier care, just wanted to have a moment to hear all from you. I have a whole list of barriers that I wanted to share with you, but if you will, either just unmute or put in the chat, what kinds of barriers have you seen to folks in your care settings accessing care? That could be they're initiating or continuing on their medications for opioid use disorder. Just pause if folks want to unmute. Yep, transportation, insurance, absolutely. Insurance, always a big one. Transportation. Yes, right. And those things lead to missed appointments. Lack of providers willing to prescribe. Yes, absolutely. And I'll speak a little to that. Lack of support, probably all kinds of support, right? Lack of providers, stigma, a huge one. Thank you. I'm going to touch on that one shortly. Yep, patients not coming for it. Yeah, absolutely. And that can be for stigma, that can be for transportation, availability of meds, prior auths, yes, financial issues, family care systems and prescriptions not approved. Yes, afraid of what people might think about them. Absolutely, right? We know that stigma is still very strong for MOUD. Fantastic. Well, thank you for this list. That, again, adds more things than what I had previously. So for my future presentation, I'll include some of these. But these are several of the big ones that I see and sort of that you all have highlighted. So missed appointments and late arrivals, right? That often relates to transportation, as so many folks have mentioned, or sort of other social chaos or needing to prioritize other issues in their lives. Delay in medication start is another one that we see, and is definitely evidence in the literature that when folks are sort of in that moment of readiness to change, they need to be able to start their medication right away, ideally that day. Otherwise, sometimes the zeal sort of goes away and the moment is over. Pharmacy and insurance challenges, obviously huge, enormous, that need to be tackled on a systemic level. Expectations and ongoing substance use. So this is one also that, a lot of more traditional programs have expected abstinence, particularly from opioids, but from all other substances as well. And that's challenging for a lot of folks. Someone mentioned judgment and stigma. Absolutely, and there's a lot of good research that shows actually from that syringe service program survey that I mentioned earlier that when folks report that they don't present to medical care, fear of judgment from doctors is usually kind of the number one cause that's reported or the reason that's reported. So obviously a huge one. Triage of needs. So again, folks with a lot going on in their lives who might need to prioritize their housing for the night, getting food for the day, picking up their children, and so just can't quite make appointments happen. And then also dosing limits. I'll talk a little bit more about this, but some folks who are, especially in the era of fentanyl, sort of being underdosed and not getting their the full treatment effect from medications for opioid use disorder. So a lot of barriers to tackle. So low barrier care is one way that we're trying to tackle that. So what is low barrier care specifically? So there's a growing body of literature on sort of these very specific care models, and I'll outline what those are. But really to me, what this means is it can be very general and very small even, but it's any practice, any strategy that you or your clinical setting is using that's intended to engage and retain folks in care, regardless of how complex their disease is. Or really, to me, in other words, it's like making it easier to access medications for opioid use disorder than it is to access heroin or fentanyl, or than it is to be incarcerated. So that's sort of what it boils down to me. And really asking ourselves for every single patient, what more can we do as a care setting to make them feel welcome and help them continue to return to care? I guarantee, of course, you are all already doing many types of things that are trying to lower barriers for your patients. So I'm excited to learn about those as we go along. And my hope is that we can all sort of share ideas. I will present some, but I know there's a plethora of knowledge and experience in the audience. So I hope folks will also share ways that they've been able to do this. So before we move into more discussion, what is sort of low barrier care is designed as explained in the literature. So kind of key characteristics that we see showing up are rapid access to care and medications, as sort of I mentioned, ideally that first same day start, a harm reduction approach, and harm reduction is really, I'll talk a bit more about it later, and most of you are probably familiar, but goal is sort of recognizing that ongoing substance use is a part of life for some folks, and how can we keep folks the safest and healthiest as possible while they're in their substance use. And that kind of goes along with redefining success for every person, trying to empower folks with knowledge, help people feel really dignified and respected in care settings. Third component is really flexibility, and this is all kinds of ways. Many programs don't have specific appointments. They're on a walk-in basis. There's usually no punishment for any missed appointments. Polysubstance use is typically accepted. Telehealth is often offered, and various types of ways to start on medication, as it is often hard to do the more traditional start, particularly in the setting of fentanyl, but a lot of places are doing that. Convenient location, making sure that care is being delivered in places that are convenient for the patients and the community members instead of what's convenient for the medical team, which is more typically how we've designed care. And then finally, behavioral health is usually not required in these programs. It's usually offered and very much encouraged, but not mandated in order to receive or continue in getting MOUD care. And in some programs, again, I mentioned like drop-in hours are available. A lot of folks have peer support and other kind of multidisciplinary team members to support the patient in addition to the provider. Other non-medical services on site. So that might be providing transportation vouchers. It might be having a food pantry, clothing might be available, kind of trying to meet the other basic needs of a lot of the clientele. Some programs actually do have an on-site pharmacy that's able to dispense buprenorphine, which helps certainly with a lot of those pharmacy barriers that were brought up. And some programs even have the availability to give free medication if someone doesn't have their Medicaid active or if someone doesn't have insurance. Many programs also have sort of a mobile or an outreach component. So whether that's the provider going out or whether that's team members going out into the community where folks are, and then being able to call back and do telehealth with the provider. And trauma-informed care, I think, generally is underlying most of these programs that are highly effective. And I won't dive into the huge details of that. I know there have been other amazing presentations on trauma-informed care, but really just understanding that, most folks who are coming who have SUD have a history of some kind of trauma. A lot of that trauma can show up in the medical setting, and it can help folks or it can discourage folks from seeking medical care. So really making sure staff are trained in trauma-informed care, oftentimes having a peer or a patient help design a physical space, help design the workflow in a way that kind of recognizes that history of trauma in most folks. So those are sort of the main principles of that type of care. And so, does this stuff work? That's an important question. And what I will say is, data is still fairly new. Within the past 5 years or so, these types of models of care are popping up and being studied. Most studies look at retention, but there's a lot of discussion of sort of what are the right outcomes to look at. But I'll just discuss retention a little bit here since that's what's most looked at. This data comes from Seattle King County Public Health, which was one of the first low barrier type of clinic in Seattle. And they looked at sort of retention over the course of 180 days or 120 days, I'm sorry. And they sort of divided folks up into like low level of retention, moderate retention, and high retention. And they found that sort of, looking out at about 120 days or about 4 months, about 1/3 of folks were retained in care. And 83% at least had one follow-up. And this was a population that was otherwise really not engaged in care other than occasionally going to the ER, most typically sort of an unhoused high-risk population. Similarly, several other related programs have seen similar results. So the diagram on the left is showing a street-based clinic in San Francisco. And they showed similarly, they're looking at retention on buprenorphine and in care here, which mostly parallel each other. And they saw that at about a year out, about 20% of folks were retained. And similarly to bupe pathways at the prior study I mentioned, about 1/3 of folks were retained at about 4 months. And then finally, there was another study done, and this was a low barrier SSP-based clinic as well, who saw very similar retention as the other ones that I just outlined. And then they also, as this graph is showing, just kind of demonstrated that the longer that folks were in care and getting urine drug screens, they saw, opioid use significantly fall off, and then buprenorphine positive urines increase, which is certainly what we'd hoped for, but helpful to see it actually bear out in the evidence. So what do we make of this kind of data? In my first glance, like, 1/3 of people retained at 4 months doesn't actually sound all that fantastic. However, if we think about two things, so one is sort of what does the literature show in terms of other MOUD programs and how well are folks retained in care sort of in a non-low barrier setting. The range is very large in the literature, ranging from about 20% up to 80%. And that's very dependent on the population that is being looked at and how retention is being defined. But what I would say is these low barrier programs are sort of showing retention sort of within that window of what other regular programs are showing. And also these are getting access to the folks who are most vulnerable and typically not engaged in care at all and have the most kind of psychosocial chaos going on. So I think with that perspective, it is actually quite effective. So I want to now kind of move on from that and talk about a little bit more about sort of, we're all in different realities. Probably most of us aren't working in this type of setting at this point. We're not necessarily in an SSP providing prescription care there. However, what can we really do sort of in our own care settings? So that's what I want to focus the rest of my time on. I'm just going to peek in the chat and make sure I'm not missing anything, any questions or anything that are popping up. Sorry. Okay, great. So first, I want to just touch on sort of structural things, recognizing that, again, most of us are not, we don't necessarily have the bandwidth. We're not in the leadership positions. We don't have the finances necessarily to address a lot of these, but I do think that they're worth mentioning. Kind of thinking about overall, like what are some of the challenges we all face, and also what are some of the areas for advocacy for those of us interested in advocacy type of work. So kind of on the left, these are the barriers that we outlined earlier. So missed appointments, things that can be worked on. Again, sort of that flexibility of services as much as possible, providing drop-in services. Some clinics, including a few places in Michigan, are using sort of a nurse care manager model to make this financially feasible. Offering telehealth services as much as possible, and the rules around this may change soon in May, but the DEA is sort of considering right now. But as of now, telehealth is still available, and we hope it will continue to be the case. Also, many programs, places can offer transportation vouchers to assist people with transportation when they do need in-person care. Addressing sort of that triage of needs. Again, this is as much designing one-stop shopping programs as possible. So thinking about, what are the top 10 needs of somebody with a very active OUD and trying to make sure that all of those needs are being met in one place, right? So for a very vulnerable population, that might be, their MOUD care, perhaps hepatitis C treatment, STD testing and treatment, maybe PrEP care, and then, case management, help with housing, help with their mental health issues. Those are sort of some of the top things to try to house in one place. To address financial limitations, obviously this is a huge area trying to be worked on, but never changes fast enough. Getting folks activated on their Medicaid right away, and a lot of low barrier settings will have somebody who's able to help folks activate right away if they are eligible. This is specifically, for those of you who worked with anyone in and out of the correctional setting, insurance deactivation is always a challenge. Being able to offer free medication for folks who aren't insured is another sort of stretch goal. And then for pharmacy challenges, different tactics that can help are if you don't have the ability to have a pharmacy on site, at least developing very specific relationships with local pharmacies, finding out sort of where do your patients feel the least stigmatized, where do people tend to have the fewest hiccups, who tends to have buprenorphine available on site, and just sort of, building an actual personal relationship with that pharmacy can be very helpful. And the pharmacist will often, communicate back and say, hey, this patient didn't make it, or we didn't have this medication, can we send it somewhere else? So those relationships can be really useful. So kind of moving away from the structural things and more toward the individual pieces, which is really where I want to spend our time, and hope that everyone's able to come away with at least maybe one thing they can try to apply in their care setting. So kind of returning to the delay in medication initiation. So this is a really big one, and the literature shows that if folks are able to start on the same day, they tend to be retained in care more effectively. So as much as is possible, if you are a prescriber or you're able to advocate with your prescriber to be willing to start the medication on that exact same day, or at least prescribe it. And obviously there are pharmacy and financial barriers that can get in the way of starting immediately, but at least being willing to prescribe immediately. Second is offering home initiations. I think that this is becoming pretty standard of care, but in some places still, like office-based inductions on buprenorphine have been required, and that is just a challenge for patients. It's uncomfortable for them to be in withdrawal in a clinical setting, and then it's also challenging for the clinic to have someone there all day doing their medication start. And there's great evidence showing that home initiations are just as effective and safe. So encouraging folks to do that. Sorry, I already talked about that. Secondly, I wanted to chat about dosing limits. So with buprenorphine, for those of you not familiar, most doses of buprenorphine are, most folks are on somewhere between 8 to 24 milligrams per day. The FDA has a limit that they describe as, I believe theirs is 16. And a lot of insurance companies for a while weren't approving anything higher than 16. And now most will approve up to 24. But there is actually growing evidence showing that up to 32 milligrams. Some places actually outside of the US will go higher than 32 milligrams, but that 32 milligrams can be effective. And why I think this is particularly important is that we know that in the setting of fentanyl, people's tolerance is growing immensely, and it means that their dosing needs are much higher for something like buprenorphine, like a partial agonist. And there's been some pharmacologic studies that do show that sort of, the higher dose you go, you get diminishing returns, but you still actually do get higher receptor occupancy of the mu opioid receptors. And that translates to a more therapeutic effect for a patient, meaning fewer withdrawal symptoms and fewer cravings. So this is a study actually that was done across 9 opioid treatment programs in the US. And it just kind of maps out nicely showing, this is basically showing people on buprenorphine and people on methadone. But with both of them, the higher doses you go up to the 32 milligrams for buprenorphine actually does lead to retention in care. And since we know that retention in care is correlated with decreased morbidity and mortality, I think there's pretty strong evidence that there are some patients, not most, but some that do need to go up to 32 and that's appropriate. So working on some advocacy efforts, certainly in Michigan, for insurances to cover up to 32 milligrams, and that still here tends to be a limitation, but at least being willing to escalate doses up to 24 milligrams when it's clinically indicated is also another important way of retaining folks in care. Thirdly, addressing judgment and stigma, arguably this is what underlies all of the other barriers, right? I think we can all say that, and we've all seen how this plays out for folks. I don't think we can underestimate the power of judgment and stigma. But in terms of, what can we do? This really circles back to the harm reduction stance. And I apologize for those of you who are already well versed in harm reduction if these things seem like old hat, but I think they're worth mentioning. So again, harm reduction really is founded in the belief that substance use is a part of the human condition, and everybody is worthy of dignity and respect for their goals around substance use. So that goal might be stopping, and it is for a lot of people, but some may just want to have more controlled use or more safe use. And harm reduction really encourages that care teams align around whatever those goals are. So, how does this look, from a provider standpoint, or, conversations with patients? Just to share a few examples might be, while seeing a patient during their first visit, you ask them about their goals very specifically, and then you align with whatever those goals are. And if their goal is they want to continue using opioids, but they only want to do it on a weekend and they want to be safe about it, it's, aligning with that, validating that goal, and then helping them achieve that goal with your medical care. And then another example might be, while seeing a patient who's been on their buprenorphine and they have some decreased opioid use, but they're still having ongoing low-level use, things that you can do. So one is, of course, making sure that you escalate the dose if that's clinically indicated up to 24 or 32 milligrams, but also starting to talk to them and counseling them about safer use strategies. Are they using by themselves? Can they make sure they're using with other folks? Do they have naloxone available? Do they know how to use it? Does their family know how to use it? Encouraging them not to reuse needles, encouraging them to maybe snort instead of injecting. These are all sort of harm reduction principles you can share. And you might even then give them a brochure on a local syringe service program and make sure that they understand that they're still welcome back and you're willing to continue their care even if they're engaging in those services. Or another example might be, if you're talking to your team and seeing patients, you just are really striving to use language that always conveys dignity and respect. And actually at the end and on our MOC website, there is a language guide that I've included that, I try to sort of, keep available at all times to remind myself of appropriate language to use, because it's hard to make changes in our language. But as much as possible, sort of using person first language and a language that lacks judgment as much as possible. And then, sorry, I'm just peeking in the chat because I know there's like stuff being said. Harm reduction should be discussed along with Narcan, despite how treatment provider may feel. Absolutely, thank you. Yep, and that can always be provided, even if the treatment provider doesn't provide it, right? Everybody else on the team is able to do that. So, so please do that. And then, yep, somebody else is asking about retention, and I'll circle back to that one later. Okay, great, thank you. So then, whoops, I wanted to go back. So the last piece I wanted to discuss here was sort of the expectations idea. So again, as I mentioned, sort of in the more traditional programs, abstinence was the expectation. I think this is definitely changing, but I do think we have a ways to go. Behavioral health not being required. So there is actually a study that was interesting that showed different provider and care model characteristics that decreased retention in care, and actually required behavioral health was one that decreased retention. And so I would argue that, most patients in the end do benefit from behavioral health, but being able to stabilize on their medication first and then access behavioral health is oftentimes what is most helpful for folks. And once their physiology is stabilized and they're not feeling physically sick, most folks are much more interested and willing to engage in behavioral health. So just making sure that that's not an upfront requirement for folks, but they understand it's kind of a menu of options that they can use over time. And then individualized appointment intervals. So, there was oftentimes early on the expectation that folks would have weekly appointments or a very standardized frequency of appointments. And I think, as much as we can, just like we try to individualize all care plans, figuring out what's going to be most supportive for that patient. And I like to do this often, if I think a patient is appropriate to increase their interval, maybe from a week to 2 weeks or 2 weeks to 4 weeks, really having a conversation with that person about what is most supportive for them. And some patients will say, I want to keep coming every week. It's really helpful for me. Or, yes, that would be so helpful. Like I need to go to counseling and I need to pick up my kid and I want to apply for a job and I need that time. So I think sort of being as flexible as we can while we're still, adhering to regulatory principles and providing good clinical care, but trying to individualize how often we're asking folks to come, particularly in person, to make sure that we're, thinking globally about their recovery and not only their medication. So Now I'm doing a lot of talking, so I wanted to just pause for a moment and just hear from you all. What sorts of things have you all tried in your settings? What have you seen other folks doing, and how have those things worked? And this is the part where I'm going to take notes so I can get other ideas from you all. Let's see, I'm just reading through the chat here. Oh, yes. Oh, a question about Lara. Yes, absolutely right. For the folks that have to be a licensed treatment center, and there are specific rules about therapists, and I know there are also specific rules around urine drug screens stated. And I will say up front that I don't have personal experience with this because our center is just below that here. But I do know that there are a number of clinics that sort of strive to meet those requirements, but that when they have not met those requirements, they've said that they have not, received any repercussions from Lara, and that Lara has been overall pretty understanding despite what's stated in their regulations. So sorry, that's not the most helpful answer, but yes, I mean, I think for right now, some of the Lara requirements do run completely counter to some of these low barrier principles. So obviously being sort of in line with the regulatory bodies is the most important thing overall, and then trying to find a wiggle room where you can. And then absolutely, I think we've all heard that those requirements are supposed to be going away imminently, but have not yet. So that will be a huge stride when we're able to do that. But yeah, thank you for pointing that out. Somebody's looking for more butte patients. Absolutely. So I'll send butte patients their way. Yep, continuity of treatment when a client gains employment and new insurance with license requirements, but losing the rapport they have built. Oh, yes, absolutely. So I think Faith had written, I think this is sort of referring to maybe they're in one treatment setting, but then because they sort of start to do well, they have to transition to a new care setting. Faith, you can correct me if I'm wrong, but yes, absolutely. And that's a really tricky one. We experienced that in my prior clinic in Seattle that actually only accepted folks who were unhoused, and then they had to transition care at that point. And I think the best way that we were able to do that was, again, trying to make, and this is a lot of work on the care team end, but trying to make like actual verbal contact with the receiving provider to kind of share the background of the patient, so they understand, and then also understanding that the rules and the expectations in a new care setting might be different, so the patient sort of has that preparation in advance. Oh yeah, do I have success stories in getting nervous providers to start providing bupe? Yes, absolutely. I'm going to loop back to that one at the end. Get rid of your analysis. Yes, trying to catch them or trap them in. Yes, absolutely. And so Robert Houston brought up, right, the urine drug screen, and thank you for bringing up, that's a whole, right, a good talk all in itself. But yes, I think, lots of ways to deal with urine drug testing, and certainly like if you're a Lara site, right, there are requirements around that. And so I think, as much as folks are able to relax urine drug testing while still feeling, like they can make a good clinical judgment is important. But even in the setting where you are required to do urine drug testing, I think there are really important ways that you can talk about the urine drug testing and use the urine drug testing in a way that still sort of embraces a harm reduction lens. So things that I try to do, and folks might have other ideas on this, but I try to, just go over the results with the patient so they're very clear. We're kind of looking at it together. We're talking about it together. If something shows up that they don't think is there, we're trying to understand together what it is, instead of me sort of looking at it and saying, why do you have this, this, and this? But I say, oh yeah, okay. See, and I see benzodiazepines. You mentioned that you tried that one for anxiety the other day. I see methadone. We didn't talk about that one. How do you think that one is there? And really trying to like be on a team to understand the results of the urine drug test. And I try to frame it to folks as, our goal with urine drug testing is at this point not to use it as a way to punish them, not use it as a means of discharging them from care, but really just for us to have a conversation about what their stated goals have been around their use, and then how does the urine drug test compare to that? And so how can we help use that as a tool for them to help achieve the goals that they want to achieve? But yes, that one is definitely a tricky one. So yes, so yeah, but it is on something emergency room. Yes, some of the Wonderful. Yep. Emergency rooms are starting to start folks on buprenorphine. Absolutely. And I think that's being recognized as a huge entry to care, right? And ideally, we'll have more outpatient settings that can absorb patients. But I think right now, a lot of folks are showing up in the ER in withdrawal simply because there's no outpatient provider to do that. But no matter what, I think the ER is a wonderful point of entry for, especially for folks who just experienced an overdose, and are sort of at a moment of readiness for change, possibly. Great. And then a challenge is a clinical working with individuals have maintained abstinence from opiates while on MAT is that after a couple of years, they are no longer in need of continued therapy and case management, but no local doctors willing to ask for continued MAT. So I think definitely one big theme is the paucity of providers. And so I'm gonna go through like 2 more slides and then let's return to that and any other discussion. So right, we're all working really hard to do everything we can for patients. So I just want to sort of recenter us on, as we try to make other changes, on sort of the messages of hope and remind us of who are the people that we're doing this for. These are 2 particular beloved patients of mine from Seattle, Alicia on the left and Randy on the right. And these are just sort of some quotes from them. I want to thank you guys for all you do. I don't know where I'd be without you. Felt myself slipping backward and felt like no one cared about me. I'm really glad I have you guys to help me with everything. And she's somebody who had been sort of discharged from a lot of prior settings because of some ongoing stimulant use. And so we really got to watch her transform. And this is her. She became like a manager at Domino's Pizza and brought us free pizzas almost every week. So bad for our health, but really great that we got to see her do that. And then on the right, this particular gentleman kind of had just spilled a lot of his life story to me. And he just said, oh my gosh, wow, I just told you a whole bunch of things I've never said out loud. I've never been somewhere I can say things so honestly. And that really is not because I did anything amazing, but he was in a setting that he felt he could trust. This was in a syringe service program where he had already built a lot of trust with the staff. He felt comfortable. It was a very trauma-informed space. And so I think that allowed our clinical interaction to proceed very differently because I was sort of gifted the trust that he already had to that setting and the other providers that were there. So these are just a couple of, I tried to make some like cheat sheets that are going to be on the website, kind of outlining 10 sort of like quick ways to decrease barriers, and then 10 ways to sort of take it to the next level if you're more in a leadership position or you want to do more advocacy work. So these will be available in the slides we send out and then also on the website. And then finally, I just want to share a couple of places that are sort of doing what I think is really neat low barrier care. And of course, many of these places don't have robust websites because they're often underfunded and they're too busy doing good work and haven't been able to build cool websites. But so one is the Seattle King County Public Health, that data that I had mentioned, and that is a syringe service program based, and they were sort of one of the first in the country that did that. And then there is also, this is my old prior step clinic. This was our article in the Seattle Times where we were written up. So very similar sort of syringe service program based model. Prevention Point in Philadelphia, which has done a lot of amazing work around low barrier access to MOUD, also advocacy around trying to get a safer consumption space also in Philadelphia, which hasn't quite come to fruition, but an amazing organization as well. And then the California Bridge Program, which is actually that one has a great website that's worth exploring as well. And then there is the program in New York. I did put it on here. Sorry. Anyway, there's the first safer consumption space program that has finally been approved and been built in New York. So they're certainly doing low barrier access to medication for opioid use disorder, also within the setting of a safe consumption space. So folks are able to come in and use their substances on site, but also access MOUD care if that's what they're interested in. So some really neat places, and we'll share more probably in a few months on a webinar. We may have like a panel of some Michigan programs that are doing pretty innovative things as well. But these are some different ideas of how it's showing up in reality. And then, yes, this is my thank you slide. And then I want to return to discussion. And then there are a few other toolkits that are going to be on the website as well. So sort of this is a language guide. So if you want to, print this off and add it up, post it somewhere for you and your team to use. Please send me if you have other ideas for other terms. There are probably endless terms that could be added here. And then sort of a little harm reduction 101. And so again, these are all linked to our website as well. Great. So I wanted to just return to, I'm going to just pop back into the chat. And so I think one theme that I wanted to return to is what was mentioned was kind of the paucity of providers. And then I see a few other things here too, but absolutely the lack of providers is a top barrier, and that's particularly in rural locations, right? Urban centers tend to be a bit better stocked with providers, although not always. Efforts that are certainly underway. So one is that maybe some of you are aware that at the end of the year, kind of that part of the omnibus package that was signed by Biden included an elimination of the buprenorphine waiver that was previously required. So that basically means now physicians and NPs and PAs no longer have to get a specific waiver from the DEA in order to prescribe buprenorphine. And it also means that folks can provide buprenorphine to any number of patients that they feel appropriate, whereas there used to be a 30 patient limit or an 100 patient limit if you applied for more. So we are hoping that that goes a long way in increasing providers at this point. So currently now, anyone who has a controlled substance license to prescribe can prescribe buprenorphine. However, we're now sort of in the effort of how do we provide the right education to providers so they know that they are able to do that, first of all, and that they feel equipped with the skills to do it. And that's one of the things that the MOC is trying to work on, is sort of distilling down some additional trainings for folks, not because that training is required by the DEA, but just to get folks comfortable. And then, ideas for how to help sell providers. I think somebody mentioned this. So obviously part of my sell is just that I talk endlessly to my colleagues about how much I love it, and that it really brings me great satisfaction. So I think from the provider standpoint, there are selfish reasons to treat, right? So one is we don't have any other medication that we provide, at least in primary care, but probably in a lot of specialty care, that is as powerful at reducing death as buprenorphine is. So, we provide things like statin medications left and right 20 times a day, and that is a far, far, far less effective medication than buprenorphine is. We also provide many, many medications that are much more dangerous than buprenorphine. I think a lot of folks are worried that they're going to harm someone with buprenorphine, but because of its really unique pharmacology, it's actually extremely difficult to cause death or really to cause any harm in buprenorphine in patients on buprenorphine. Things like insulin are actually much easier to cause harm with than buprenorphine. So that can be a helpful talking point for providers as well, as sort of emphasizing the safety and then the satisfaction of watching people get better, I think are really big ones. And then I'm hoping now that the MAT Act has passed and the waiver is gone, I think folks often were a little bit fearful that the DEA was going to be after them because it was such a carefully regulated medication. And so hopefully some of that stigma and that fear is going to go away over time now that there is not this special waiver that's required. And then other things I think that can help, convince providers, like, for better, for worse, providers often like to hear these things from other providers. So if there's ever someone in your local community who is prescribing and is willing to sort of talk to their local providers, I think that's often one of the most effective ways to do it. And then getting institutional support, I think, is another really big one. My clinic in Seattle, part of the way that we were able to get prescribers prescribing is everybody got blocked out time on their schedule, their training was paid for, and everyone got to attend a training about buprenorphine. So just a little bit of that institutional support can also go a long way in helping. And then sort of, if you can, developing a local like clinic champion, right, who can then help support some of the other providers who are getting started, and telling them they can call MOC anytime with any question, little or big, and we're all really enthused to help them as well. Sorry, that was a long answer to that. So I'm gonna scroll back to what else I missed. We've just discussed the need for skilled payer for benzo and provided resources. However, a person continues to use high dose of benzos or utilize resources. So I think, let me make sure I'm kind of understanding, is this, I don't know if the person who wrote this in, is this in the context of buprenorphine, or is this sort of just a benzodiazepine use disorder question? I don't know if that person is able to unmute or say more in the chat. but I can circle back to that one.
I'm sorry, that was me. Yes, they are on Suboxone, but also keep using the benzos. High
Yeah.
doses, like 8 milligrams a day. And
Yeah.
we have discussed several resources and everything, case management, but he continues to use. So yeah.
Yeah, absolutely. So, a couple of thoughts that come to mind. So, one is, first of all, it used to be sort of seen as a contraindication to co-prescribe buprenorphine and benzodiazepines. And back in I believe it was 2018, 2016, the FDA explicitly said, there's just because someone's on benzodiazepines, it's not a reason to stop their buprenorphine use. For folks who aren't prescribers, sort of just the background on part of this question and concern is that one of the few times that buprenorphine can be dangerous is in the context of someone using high doses of other sedatives. So that's alcohol in high doses or benzodiazepines in particular. So yes, there is absolutely a risk. However, compared to the risk of a benzodiazepine plus heroin or fentanyl, the risk is phenomenally lower on buprenorphine. So we still do rarely see adverse events, but there is definitely a particular concern and a high dose. So I appreciate you bringing this up. So one thing that, I think I would probably do with this patient, if someone is struggling with benzodiazepine use disorder, I am always nervous about their buprenorphine ever going away because I know they're going to be at much higher risk of an overdose if they go back to a full opioid agonist. So I would, keep this patient in care, but I think one thing that I would probably do is, first of all, I don't know if they're being prescribed the benzodiazepine. So one, if someone's being prescribed a benzodiazepine, is talking with that prescriber and making sure that you're sort of coordinating your efforts, making sure each time you're seeing the patient, both of you are sort of assessing for any adverse interactions between the two. So things like any kind of sedation, having a hard time waking up, anything like that. And then I think part of it's going to be like a discussion on that patient. I don't know what his or her goals are around benzodiazepine use, if they're interested in trying to decrease or not. But some motivational interviewing and perhaps getting into counseling to try to work on sort of what's behind that benzodiazepine use. Oftentimes there is a lot of anxiety or PTSD or sleep issues that someone's trying to self-treat. So trying to make sure that those things are treated and addressed might be able to help them at least decrease their use, even if they don't stop it completely. I'm not sure if that's at all helpful, but I'm happy to talk further offline if you have more questions about that specific patient. Someone else said, sorry, let me see what else I missed here. Oh yeah, someone else said, do you see any clinics that are prescribing, have a similar protocol for diabetes and substance use disorders? That's such a great question. I don't actually know if anyone has tried to perfectly parallel the two. I think we're doing it loosely, but I've not seen that. But that's a really compelling thing to think about. So thank you for bringing that up. I love that idea. Let's see, how do you think the Medicaid information across the state will affect individuals that are currently in MET? Can you educate me on what I knew enough to the state? I don't actually know what you mean by the Medicaid redeterminations, Dorothy. Can someone educate me on that? And I'll try and speak to it, maybe, or when someone has the time, someone can share, and I'll try to speak to that. Let's see, I'm just scanning back to see if I missed anything else. Joanna, have I missed anything else in the chat that I should make sure that I address?
I think for the most part, we've got it covered. So I know that somebody had asked about success stories in getting nervous providers to start providing Bu.
Oh, yes, great. Yeah, that is a great question. And I maybe spoke to it a little bit, but I actually do have one of my providers in Seattle who they technically got their waiver. As I mentioned, our whole clinic kind of required everyone to get their waiver. But she was just, very apprehensive about it. She had trained a long time ago when buprenorphine wasn't even available, did her residency then. And she was actually prescribing fairly high dose full opioid agonists, which, to me with my newer training is much scarier than buprenorphine. But kind of the things that we talked about, I did a lot of talking about the safety, and I have a little graph that I like to draw about the pharmacology that can help people understand why it's such a safe medication. And then what I did was sort of try to hand select a couple of my very stable patients who were doing well and had her follow up on those so she could see sort of the after effect of what happens when people really do well with buprenorphine. And so she just saw them thriving, and they came in and they were so grateful for their medication and for seeing her. And she got to really see the power of the medication with folks who were doing well. And that sort of helped her get it. And then I did do a lot of hand holding, like, when she'd see her patient the first time, we'd talk about what she was going to do in the visit and be able to debrief it afterward. And the last piece is we built some sort of visit templates so that all of our providers sort of knew the important questions to ask. So that's another thing sort of structurally that can be useful. A lot of EHRs will allow you to build a template and even order sets and things like that that can help guide folks who are feeling a little bit unsure. But yeah, I think folks being able to see success stories is often a really good hook for folks. Just given, sorry, how do you think? Oh yeah, people were given Medicaid benefits during COVID that would not. Oh, so right, how people, yes. So how like a lot of folks who got extra, like all the extra things people got during COVID that we realized they really do need. And some of those things are now going away, such as folks who, right, were able to access food and that won't be able to. Absolutely. So similarly, yes, I do think it's going to have an impact. And I don't know if anyone has estimated in Michigan sort of what that impact is going to be, but I absolutely think there's going to be. So I think it's going to be a big gap, and hopefully one that policy people are thinking about, but I don't know if they're thinking about it very well. So I'm glad that you brought that up. And I'll have to look and see if there's any estimated size of that impact. Great. Any other last thoughts? I so appreciate everybody sharing challenges, sharing things that are working. Again, this is something I feel really passionate about and excited about. So please, if you ever have questions or you want anything that I can help you with, please don't hesitate to reach out to me or to anyone at MOC. We're all available and enthusiastic to try to help.
Thanks so much, Dr.
I'll hand it to you again.
Thanks so much, Dr. Hutchinson. Great presentation. You had mentioned earlier that it was really helpful to be able to hold this provider's hand and kind of guide her through this process of being able to prescribe buprenorphine. And I just want to remind people that's something that MOC feels strongly about and is happy to help people with. So if there are new providers or anybody that has questions about prescribing buprenorphine, give the MOC a call if you need some extra guidance, extra support, and we have same-day consultation services that we can offer to you at no cost. So if you have any questions, please feel free to reach out to us. Your local behavioral health consultant will be reaching out to you with today's slides and further information. And if you have any questions, please let us know. Thank you so much for attending today.